Thank you. I know it takes a little time to go through all the introductions. I think that's a really valuable investment of our time to build some community and hear from all of you about what you're doing while sheltering in place, the questions you have, some of the emotions that come up, whether it's anxiety, fear, and also remembering those moments of joy and what brings us joy in these times. Our goal right now is to go through sort of like a little bit of quick information sharing. This is not going to be a PowerPoint deck. I will share my screen with in a minute with to go through some of the sort of resources that are available and just make sure that we can point people to trusted sites that do have updated information. Just because there's so much out there. It's just a torrent of information all the time. And some of it is misinformation, and it can be really hard to tell what's real and what's not. And so that's one of our goals, is just kind of dispel some myths, level set a little bit about coronavirus, and then leave plenty of time to talk about the questions you've already asked and other questions that come up. So we'll do kind of a quick overview. We'll talk about sort of the global situation, the San Francisco situation, and then we'll start to narrow down into COVID-19 and sickle cell disease, talk a little bit about the health inequities and the disparities that we're starting to see, and make sure we cover sort of links and resources for everybody, with plenty of open time for Q&A.
Excuse me, Ari, before you get started, I may have missed this because I did tune in a little late. Is all of these resources, all this information you're about to give us, is there a way for us to get this after the fact? Are we going to receive an email with like a breakdown of what you're talking about now? Or do I need to write furiously?
No, please don't write furiously. We are recording this and we will share it with you. And then the other thing is that we are happy to send out a list of links to the internet resources that we find most trusted.
Thank you so much.
Thanks for raising that. And feel free to jump in anytime. So just a few basics about COVID-19 and what is COVID-19. So COVID-19 actually stands for the CO is coronavirus, or the CO is corona, the VI is virus, and the D is disease. So it's coronavirus disease, and then 19 is 2019. And that's because it was a disease first realized in December of 2019, just before the new year, as a sort of a cluster of these patients with pneumonia were being seen in Wuhan, China in December. It turns out that COVID-19 is caused by, and for a while it was just called the novel coronavirus. It's a new coronavirus that sort of came up out of China. The theory is that it came from this wet market in Wuhan, China, where there's a lot of close contact between animals and humans, and that that this virus emerged from bats, similar to other coronaviruses that have come up in the past. So coronaviruses are actually like a family of viruses. There's a bunch of different ones within the family, and a lot of them just cause common colds. So we're really used to seeing coronaviruses in the world, and they cause all kinds of different common colds, sometimes lower respiratory or pneumonias, like actual infections in the lungs. And this one is really similar to, but distinct from SARS, which is severe acute respiratory syndrome, which is also caused by a similar coronavirus that came out as an epidemic in East and Southeast Asia in 2003, I believe, was the first SARS epidemic. And so these are these what happens is that these viruses going between animals and humans can mutate in an animal and then jump into humans as sort of a new form of a virus that we are not immune to, and then depending on the features of the virus and our behaviors as humans, spread among humans. So that's kind of the broad overview of this particular coronavirus, which is actually the virus itself is called SARS-CoV-2, and then COVID-19 again is the disease caused by it. So a lot of questions about how it spreads, and you guys had some really great and specific and nuanced questions about the spread of this disease. What we know, we do actually know a fair amount of the science. So the primary mode of transmission for this disease is what's called droplet transmission. So there's a lot of like sort of infection control terminology that's been thrown around that I think a lot of us aren't used to. Like, what does droplet mean versus airborne versus contact? And these are different ways that we can transmit infectious disease to each other. And so droplets are these heavier air particles that you breathe out. They're like the moisture in your breath or your cough or your sneeze that can contain the virus. And it can float only a short distance in the air because they're heavier particles. So they drop usually within 3 feet. If you're really like coughing hard and sneezing up a storm, then maybe out to 6 feet. But
hey, Ari,
what's that?
Ari, I'm sorry to interrupt. I had a question right before you got into the droplets portion, and you were talking a little about the history. I was ID'd by a few friends of mine to look on like a Clorox bottle like this, or something that's a little bit more like bleach. And on the back, it talks about this bottle fighting against coronavirus. And this is a label that was actually coming out from a long time ago, not necessarily for 2019. Why is that on those bottles? Or is that a question I should be asking later?
No, that's fine. I mean, I can just take that right now. It's the coronaviruses, because there's all these ones, like I said, that cause the common cold.
Right.
We've known about coronaviruses for a long time and been infected with other coronaviruses for centuries. So it's just listing a bunch of common viruses that cause things like cold, and I'm sure influenza is on that list of things that it kills. And I'll come back around to that in a second, but just the main way that we infect each other as humans is through these droplets from coughing and sneezing. And again, that's pretty close contact. It's not like these tiny particles that float through the air and then just go into the air systems. And, like if somebody with coronavirus walks down the street and then you walk down the same street, that's not how it's spread. It's prolonged close contact through these droplets that we breathe out that stay pretty close to us. So that's actually why the social distancing works, the physical distancing, again, to our earlier conversation, that it's not social distancing, but physical distancing. But by staying physically apart from each other, the 6 feet on the conservative side, you give 6 feet of space, you don't even need a mask. That's enough to keep you from getting, from transmitting droplet transmission from one person to another. The question about masking, I think we'll come back to that in a second, but I want to just say one other way that people talk about transmission of coronavirus, and that's through contact on surfaces. And so a lot of questions, and Yemi, you raised a really good question, like, is it on the cash in the ATM? Like, that's all of that has come up a lot. And there's some that we know, and then there's some that we don't know about that. So what we do know is that coronavirus, like many other viruses, can live on some surfaces. Mostly it's not stuff like the paper of cash or, you know, your mail. It is like frequently touched hard surfaces like doorknobs, iPhones, etc. that people, these hard surfaces, there have been some scientific tests in labs where they look like, okay, well, we can still detect viral DNA or RNA, like the genetic material of the virus on these surfaces after a certain amount of time. And without going into all the details, the problem with that is that we don't know that that's actually, it doesn't mean that you can get infected from it. Just because there's a little bit of genetic material doesn't mean that the whole virus is actually like viable, that it's capable of infecting you. And we still think the primary way that people transmit the disease is through those droplets of coughing and sneezing, through close contact. The question about the surfaces is like, if somebody wipes their nose because they got a runny nose, grabs a doorknob, and then you come along, grab that same doorknob that's got virus on it, and then rub your eyes, put your hand in your mouth, whatever, like touch part of your face, that's a possible way that we transmit the virus as well. And so because of that, that's why, in addition to the physical distancing, and actually even probably more important than the physical distancing, is just hand hygiene, washing your hands, hand sanitizers that are alcohol based, and then not touching your face, which is super easy to say, super hard to do. But those are the three biggest things we can do. So again, it's not touching your face, washing your hands, and the physical distancing recommendations. Those are the public health interventions that decrease the amount that we transmit the disease from one person to another. And I'll just say that, oh yeah, go ahead.
Just a statistical question. I was reading something about the normal human being touches their face 350 plus times a day, or is it more than that?
I don't know the data, but that sounds high to me, but I wouldn't be surprised just how, like, it's just your nose itches, your nose gets runny, you want to wipe it, like scratch your face, get a little like gunk out of your eye. I mean, it's a natural impulse to touch your face. And then I think a lot of other like behavioral tics or whatever, just to, I mean, like I often like lean my hand on my face, and these Zoom calls are funny because you can actually see how many people are touching their face on the Zoom call, and I catch myself all the time on a Zoom call touching my own face. I'm like, oh, really obvious. I didn't caught on camera. So I don't know the data, but yeah, it can be really hard to do. So that actually ties in nicely to the conversation about masks, because like I said, masks are really, I think the conversation nationally about masks has been really poorly done. Like the communication out of the CDC. I don't love the way that it sort of shifted over time and the way that it was talked about. But I think the benefits of masks are really of everybody wearing a mask in public, really low compared to those other things we just said. Again, droplet transmission. So if you're physically distant, you don't need a mask. The addition of a mask may help people touch their face less, right? Because now your mouth and your nose are covered. So it may actually help just because of that alone. And then in places where you can't physically distance yourself, then I think it does make sense, because you just have people in close quarters. And we're actually doing it in the hospital for that reason. Like the physical space of the hospital is not that well set up for everybody to stay apart. Like a lot of the workstations are right next to each other. We're sitting on a computer right next to each other in the hospital. So our hospital systems, I don't know about all of them, but many of the hospital systems moved to have all the healthcare workers wear masks throughout the workday in common areas. But again, it's because of the difficulty creating that physical space, not because it's better than the physical space. It's clearly not as good as the physical space. Questions about that before moving on?
Yes, yes,
Yeah,
yes, please.
I see one about reuse.
This
Oh, and we
is
had some other ones, but what?
this is Kiki.
Hey,
My initial question about this was the benefit of masks for our patients in the sickle cell community. Do sickle cell patients have a greater risk of receiving germs through these droplets? And because a lot of patients have, compromised immune systems simply because of sickle cell, would you recommend that sickle cell patients wear masks to protect themselves on a regular?
thank you for raising that. I see Eileen look like you were about to speak. Do you
That's
want
okay.
to?
So I think that's a really good question, and the vulnerability remains the same in any of our population. So who is more vulnerable? And I can maybe talk briefly about why some of our community is more vulnerable. And you're right that those living with sickle cell disease are more vulnerable. So who we have found is much more vulnerable is the elderly, mostly because they're already compromised with often both lung and or heart disease. So we know that the severe COVID, which is the actual, you can get the coronavirus. We hope you don't have it, Kimball, but you might, and that's okay. Your body will fight it and you're doing okay. And you will develop some immunity to it. We know that there's some immunity that develops. We just don't know how long the immunity lasts for coronavirus. And this is true of any of these respiratory viruses. So the question is, how do we protect those people? And it's the same thing. Where might you be more vulnerable? That is, if you can't socially distance, for instance, can we help our community living with sickle cell disease not have to go out as much, like get groceries for themselves? This also ties into how can we support our community? So finding ways to help the elderly or those living with lung and heart disease chronically, or living with sickle cell disease, how can we help them maintain that social distance such that a mask is not actually going to add any benefit? Avoiding obviously coming to them if we are sick, but we can drop off groceries at the door. They can open the door and pick them up. That transmission of touching, they can take out the groceries, wash their hands, and even if viruses can for a short time live on surfaces, they're not made to live on surfaces, or we would just be coated with virus. They're meant to live in biologic tissue. That's how they live and replicate. So they can survive some time, but we don't exactly know the survival. We know they're detectable by DNA, which doesn't mean they're alive, as Ari mentioned. So I think masking is the same for our high-risk patients. It's just trying to help our high-risk patients ensure the safest, which is good hand washing, not touching their faces, and social distancing. And if we can reduce the situations in which they cannot social distance, then masking is not going to be as important. But anytime, like I can maybe just share, I don't have sickle cell disease and I don't have a chronic lung or heart disease. My husband and I don't wear a mask when I go to the grocery store. And that's a complication because literally I would be taking masks from the hospital, which I personally don't think is ethical for me to take for my personal use. I leave it at the hospital and use it when I'm there. But we go to the grocery store, we stand our 6 feet apart, we give people a wide breadth, but even within 6 feet, it's not instantaneous. So to also help relieve, I am in no way saying that the social distancing is not absolutely important, but to help relieve some of that fear that just walking by someone within 5 feet is very low risk. Obviously, they don't cough directly in your direction in that moment, but that's why we keep 6 feet apart, because you can't guarantee that. But even in the grocery store, if you're in an aisle that you have to walk within 3 feet of someone, just pass them, and that still is okay. And then what we do is we stand our 6 feet apart in the grocery line, and then as soon as we get to our car, we keep a little hand sanitizer. We immediately sanitize our hands before we start touching, we touch the door, but we don't touch the car surface and the seat belt and the steering wheel, those kinds of things. Or if you have to take public transportation, you know, that's a big concern. Like, can we sit far enough apart, and trying, if we can, either just alcohol or one of the Purell substances to clean our hands when you get off the bus, even putting your hands in your pocket so you're not tempted to touch your face. I know I'm sort of expanding details, but giving some examples that if those are practiced, that we can stay away. A mask, even to our vulnerable population, doesn't add additional benefit. But I think it's reasonable to do that, because I think one of the questions was, can we send masks to our population? Well, I think having a couple masks on hand when you have to go somewhere that you can't stay apart is quite reasonable, because we really don't want our population, anyone, but especially our vulnerable population, exposed.
Question.
So speaking,
my apologies, Kimball. Question to that, because I think, and Kimball might actually expound on this or not, but I think it's important that you mentioned that, Eileen, because as a CBO like ours, as well as Carolyn Rowley's, we're a wellness center, and then Kiki with the organization, you know, we're all in a position right now where we're getting funding to produce these resources for our communities. So just understanding more and more what are the best specifics to put into our resource bags that we're going to give out to these people is important for us to truly know right away.
So one thing I would say, I think a question was asked about the different masks. I'm not quite going to get into, I think, Kimball, that was your question, or I'm sorry, whose question it was, about how much can we reuse them. I will say one thing, the full N95 like respirator, those are not needed. So those are for airborne, like chicken pox is airborne, tuberculosis is airborne. So those float, right? So you need more of a seal. That's number one. Number two, about those masks, the N95, the true cupping ones, you know, the green ones or the white ones that have the holes things, those need to be effective, they need to actually be fitted to one's face. What I mean by that is not custom made, but we as healthcare providers get what we call fit tested, because there are 3 or 4 different forms of those masks, at least in like within, for healthcare workers, and there's others floating around commercially made, that we actually literally put them on, and then we are put in head chambers and get like different caustic smells. And if we can smell them, it means the seal is not protective. So, and if you have a beard, they don't work because they don't seal. So they're sized for our faces, like, you know, largely, are you small, are you medium, are you whatever. So we would love to help, you know, use, like you said, Antoine, the funding should go to what is actually appropriate, which is a simple surgical mask. Or we know that it does not as much, but it protects to have a double cotton, or what we can add is some information about even people making their own masks, or, you know, a bandana, you know, those kinds of things where they're not as perfect and we don't have perfect scientific data. But even those TB masks are like 98% effective. The surgical masks are in the 90s effective. And that is effective in, if you are in direct contact with someone with a proven infection, right? So if you're in public with you don't know what, the risk is so low already. So if I could say, I mean, it's hard, I'm not an infectious disease specialist, but, you know, from everything we're taught by our colleagues is, you know, if we were to put resources somewhere, it would be making sure that, you know, maybe a package of Purell, or, you know, that's a brand name, but some kind of hand sanitizer, you know, that they can pop in their bag, that if they have to go out, immediately sanitize your hands. And then maybe, you know, a box or a small number of masks, just simple surgical masks, but being very clear, like, what are the use cases where they will be the most effective? Like going to the grocery store, you have to go to the hardware store. I'm just trying to think of where people will be going right now.
Yeah, it's those places where you can't be distant.
Right.
But not wearing it all the time, which also ties into your reuse question, because they do wear out, they get wet from all the moisture in your breath, and then when they get wet, they're not effective anymore, and so they do have a time limit on them, and but you can reuse them as long as they're dry and they're not contaminated, and so, you know, it's just a matter of using them only when you need them.
right, so keeping that in Can I add something to that too?
Do.
I just wanted to say that also the masks are not, the surgical masks, they're not an alternative to what we know that actually works, which is social distancing and washing your hands and keeping your hands away from your face, which is hard to do. Another practical tip that I learned recently is I had tried to go to the grocery store at 8 o'clock first thing. I am not a morning person, but I just wanted to go and get in and get out. But I was turned away actually because I'm a young, healthy person. So people in the Sickle community, elderly patients or immunocompromised patients or patients with chronic illnesses can go in that 8 to 9 a.m. hour for most grocery stores, and it's much less crowded, and it's much easier to keep the physical distance from others. So I know that that's a potential opportunity to be able to, get your needs met without necessarily unnecessarily exposing yourself. But yeah, the masks are not a substitute. They can add, but they're not a substitute to what we know actually works.
And there's
also. So with that in mind, can the mask?
Sorry, Kimmel, go ahead. Sorry, go ahead.
So with that in mind, we were talking about cloth masks earlier. We found some on Amazon as well. One of the things that I've come to find, sadly, is that a lot of companies, a lot of people are kind of taking advantage of the situation, and they're offering fake emails, fake phone numbers, that there's a cure for COVID disease, there's vaccinations, which is utterly and preposterously a lie because there has been no vaccinations approved just yet. And similarly, there are some companies that are basically marketing that they have this fix-all mask and everything. So when we talk about masks, I'm glad that you brought it up, Eileen, in terms of the surgical ones, because a lot of people have been talking about the NP5s or whatever, the N5s or whatever. And, given the background that I have, everything that you said, Eileen, makes sense. Like, you have to be fitted for those higher level masks. So it wouldn't make sense for someone to go in and use their money unnecessarily on something that they really don't need. And also taking away from what the PPE that the actual professionals and healthcare providers actually truly need to be able to go there. So we don't want to limit those resources. But keeping that in mind, when we look at those cloth masks, are those as effective as a surgical mask? Or should we just strictly be looking at surgical masks if we were to provide masks? And going along with what everybody said, again, it's just an added tool that we can use in our tool belt to have. It's not something that we have to have necessarily. But again, for those circumstances that you obviously said to, and also I believe that, if you are just getting over something and you are coughing and sneezing sometimes involuntarily, it's nice to have that mask on because then it captures it for yourself and you don't have to necessarily go around spreading it. So I think that's another added benefit of the mask. But again, obviously not to replace washing your hands, which let me say we should have been doing since the day we were born. So if this is what causes washing their hands, then we should have definitely been
okay. We got another question here. We have one more question here. Go ahead.
What are the procedures for using hand sanitizer with alcohol and the soaps that are not alcohol based? What are the procedures?
So a good hand washing is, some of the things that people say is to sing, not really fast, but sing happy birthday. And the key with any kind of hand sanitizing is also the friction. So you take a little bit of soap and water. It's better if you wet your hands first, then get some soap. And essentially there are videos and things online that, shows how long you want to wash all the surfaces, get in between the cracks, keep doing the friction like this for the full 15 to 20 seconds. That's the same process with the alcohol base. So you take a little squirt and you want to make sure the whole surface is covered and you keep rubbing it until your skin is dry.
Fingernails like this.
Do all of those surfaces.
All right.
Can I ask one question?
Now it's hard to get sanitizers.
On that, real quickly, can I just emphasize this actually is very easy to kill. So just so that people know, it's not that this. There are some things that are much harder to kill, but this is not one of them. This is easy to kill. So when you wipe this down, you don't need to have some crazy bleach product when you wash your hands. Any soap works. You just need regular soap and water.
Soap and water to clean your cabinets is plenty. To wipe down the surfaces in your house, it's plenty.
Yeah.
This is I guess one thing that I will say is, I think we don't talk about it in these terms, But every year, the world experiences an influenza pandemic.
Yep.
Every year. I mean, there are 45 million people this winter alone who were infected with influenza, true flu. So that is happening. It's just there's a massive difference.
True flu.
In this pandemic and coronavirus is that, number one, it does appear to be a bit more infectious, meaning the flu, if one person has it and coughs on directly into the face of someone else, they infect 1 to 1.5 people before they recover, usually. And in coronavirus, we estimate that is 2 to 3 people. So one person before getting better, or heaven forbid dying, infects 2 to 3 people as opposed to 1 to 1.5. So that's why this pandemic has spread faster, number one. Number two, no one has been vaccinated. So we don't have an immune population, because in influenza, so many of us get vaccinated that even if that one person coughs on someone who's vaccinated, that person doesn't get sick. Blunt the infection. So there's a couple different matters. And then a third piece, that one of the reasons it's been so deadly is that this virus, for those who have bad lung disease or heart disease, it's causing in some people a very severe lung reaction and inflammation that is leading to their severe illness and for some people, their death. I think the piece that is really hard for us to tease out right now, and that I think when Ari, maybe you can share some of the numbers. If you look at the death toll that it has taken in a place like California, where our health system, thank God, has not been overwhelmed, maybe a little bit in Santa Clara County, but our health system, because of the shutdown, has not been overwhelmed, whereas New York, New Orleans, those kinds of things, there's some pieces there where I think we have to be careful in not attributing all of these desperately sad deaths to being that the virus is more deadly than the fact that it overwhelmed our ability to care for people that were very sick. So it's going to take some time for us to tease out that difference of where is it the virus and the disease that's really causing this deep harm, and where is our health system failures causing these deep harm. And I'm just going to, I think you mentioned it, but I'm just going to plant the seed for later in the call. We know that there's a health system massive failure, which I think this whole group is known for a lifetime. But I think the public is seeing that if you look at the patients who are infected with coronavirus or who get more severely sick or who die, it is disproportionately those who already suffer health inequity. And that includes our Black Americans and Latino Americans. If you look at the populations who are sick, so just acknowledging that we do not right now have any thought or theory that it's because those people will get sicker from the virus itself, but it's that they are already living with an inequitably high level of sickness, such that the same amount of virus sickness is so much worse for them. So I think the teasing out of all of these things and who is vulnerable and how do we protect them, I know we've sort of gone beyond that other conversation, but I did want to ask Kimball for a moment, what is the name of the mask that you're saying? I'll be real honest, I don't know the different terminology, so I wanted to look it up. You said it's called a cough mask?
Which, the fake one or the one on Amazon?
I think you said cloth.
Yeah,
cloth.
cloth.
Oh, cloth. Yeah. We can send you some more information about that. We're not experts in it, but there are some thoughts about even making one's own mask, and what materials are better for that, what might help. But ideally, if we're going to give it in a kit for our population and have them use it judiciously in situations that they cannot social distance as well. I would say the true masks that are like medical masks would be the better proven option.
That's
Okay.
there have been some studies, I don't know about any on this particular virus, but like studies of just the effectiveness of different masks on other viruses, including other coronaviruses like SARS. And it's pretty clear that regular surgical masks are better than cloth masks, but that cloth masks may be better than nothing. And so it's sort of like just a matter of gradation. And again, just emphasizing that none of them are better. It's an add-on, not a replacement to the physical distancing, hand hygiene, and avoiding touching our faces.
As I'm doing right now. I don't know what I'm doing, but I just wash my hands.
You're physically distant from us, so I think we're okay.
Okay, so this is Kiki. So then my understanding from what both of you have just said is that providing our community with masks, if they are made by, because getting surgical masks is almost doggone near impossible. Don't you agree? At this point, to getting a quantity, let's just say even 100, a quantity of 100 surgical masks is doggone near impossible. And I sort of agree with Eileen that I think that those things need to be left within our hospitals, because our first responders, all of you all that are taking care of patients in the hospitals, need all you can get. So having said that, if I have a person who can make masks, what is it that, more than the cloth mask, what is it that's in the middle that should be put in to make sure that they are as similar to surgical masks as possible?
That's a great question. I don't know all the answers to that. I've seen a bunch of stuff come out about like using like vacuum cleaner filters and all that kind of stuff. Or like filters from, I don't know. I think, I don't know if Eileen or Bimpe, if you know some of those answers, but I do think that I don't know. I would try, I guess, to work to like source from like places that as like the production problem is starting to be addressed in various ways, I would try to like source and figure out what we can to not leave this to like a bunch of us like in our homes trying to figure all of that out.
I can try to look.
We could take that on.
There was something that our infectious, so thankfully we have this incredible resource where our infectious disease department is sending out a daily digest to our health system providers. And I believe that in one of them, it outlined like, what do we think is the tiering system of like the TV versus the others. And so let me try to find that, and we can send that as a follow-up, Kiki. And that it's not that we're saying this is an endorsement, but what I recall from that is like at least 2 layers of a cotton material.
Yes.
Around 75%, is sort of, if you consider these surgical masks 95% effective. And so let me look for that and see if we can help with as good information as we have and try to be a resource to the community to answer that question.
Thank you so much. Thank you very much.
Thank you.
Yeah, I wanted to just kind of, maybe this might be beating a dead horse, but I just wanted to ask about the caution, because I do hear a lot of people that will talk about how you can make your mask more effective. But unfortunately to me, these are people that are not professional mask makers. And it's not like it's very easy for us to look on YouTube, see something and be able to reverberate that, because we may not have the expertise. So how do you guys feel about that too? Because there's a lot of people that are trying these in-home things that could possibly be nowhere close to being effective as they think they are, simply because they're following a YouTube video.
I know, that's terrible.
I agree. And also the biggest thing that has been on my mind about this sort of, I'll be real honest, it felt like a flippant comment. Like, I will use the word flippant. Ari said he felt like the conversation didn't roll out as well as he had hoped from the CDC, is that my concern remains, as exactly has been said as well. I think our biggest message to our community is this is absolutely not a substitute for social physical distancing. It is an added piece if you absolutely have to stand within 6 feet within someone for 10 minutes kind of thing. And in that case, it remains, our infectious disease specialists still say that universal masking for the public is really not necessary. The infection risk is infinitesimally low, and that we should target those who are more vulnerable and only in like enclosed spaces where they can't be apart. And honestly, I would say really exploring with our clients or colleagues or community, how can we keep you out of those spaces is really the question. How do we go to the grocery store for you? How do we do these things for you?
Yeah.
Because if we can't get you a mask, to have that added 25%. So I agree with you and not endorsing, because honestly, I'm really worried that I'm seeing folks exercising in masks in the street. And first of all, I worry that that's harmful. You're just rebreathing your carbon dioxide over and over, that I feel like that can't be good from a fitness standpoint. So yeah, I'll just stop there. I know that we've said the same thing over and over, but
no,
I
it's
feel
actually not very good. Just let everybody know it's not good. It's not good. It's not
Can
good.
I ask, Bimpe, do you have any thoughts from like up in Seattle, just because it's a different geographic area, and there's a lot of variation across the country. Any added thoughts on the mask conversation?
Yeah, it's a really good conversation. It's a really important one, but you are right. Everybody's sort of addressing it the best way they can. I can tell you that I don't know what goes into making a safe home mask. I don't have that information. There is a lot of information or misinformation overload on YouTube in particular. I think one thing that I found helpful in Seattle, because we were so worried about being overwhelmed, and we have been prepping for the surge because we were hit, a little bit earlier than you guys, than in California. Our laboratory colleagues who are not actually in the labs anymore, so the basic scientists at our university, donated their masks to us and donated their gloves to us. And so once again, the people that are the first responders and the people that are on the front lines are the ones who need this more than anybody else.
Yeah.
But I don't know what goes into making a home mask, but we have told our non-health workers, and so, the people that are in our like building facilities who are cleaning the facilities after we leave, or who are helping with ancillary support around the clinic or the hospital, they can wear the surgical mask when they're working, or if they don't have access to a surgical mask, the home mask is fine too. And so that's how that's being dealt with in Seattle in our center. But I know it varies everywhere. And you're right, the information, it was very ambiguous. Everybody should wear a mask. You should wear a mask all the time or not. It's very difficult, I think, to find a reliable source. I think the CDC is a good resource, but sometimes the information is confusing and ambiguous. And so I think this sort of forum of talking it out amongst ourselves is very helpful. And you can, reach hopefully a reasonable consensus. I think is very helpful. So the practice over there is a little bit different than here.
But I do think Eileen's point about supporting people in the efforts for physical distancing is an important one, because it's really hard. It's really hard to do. And it's harder for some people than others. And people still need food, and we all have like basic household needs. And so I think in the ways in which we can support people to like get, like Eileen said, like maybe it's grocery shopping for people, because that's hard. And then I love, Bimpe, your point about just the practical tips too, like that grocery stores, I don't know if it's universal, but I have seen that as well. A lot of the grocery stores have dedicated times for, I've seen it more as like elderly, but I don't know if they like categorize it as any vulnerable group.
No, it's listed as elderly, but I know one person who went in, somebody with sickle cell, and he said, "Oh, I have am immunocompromised," and they let him in. He's a young person, so I don't know if it'll work universally, but it was just a thought. I'm not sure if it'll work though for everyone.
Well, I think it's also, but that brings up a really good like advocacy point, right? Like we as a group could advocate to our local stores, like, look, we actually think that we appreciate what you're doing. This is a really good policy to be dedicating time out of the day to protect more vulnerable populations like the elderly. But let's remember that there are non-elderly
Yes.
who are also vulnerable or at increased risk. Can we think about ways to expand that criteria like more explicitly so that people don't have to go up and ask or like explain that they're immunocompromised? So I think that's a great opportunity for advocacy for the group.
So Eileen, I was curious to know, because I'm not totally sure if this is good to start yet or if Ari's going to get to it or not, but I remember Kiki asking the question about gloves and sanitizing, like those things. How do those surfaces differ? Because obviously your skin is completely different from gloves. So gloves are made for you not to allow things to stay on them for very long. But there's this whole thing now about cross-contamination and how gloves are actually not effective. They're much more infectious. Mm-hmm. So with that question in mind, people are talking about washing their masks now. People are talking about washing their gloves. Does that lead into more information that we can find out about?
I mean, that's a really good question. I personally don't know of anything where, because gloves are, you're right, is made to substitute to be a barrier. So I don't know of anything scientifically, Bimbe and Ari, definitely please do jump in, that like using Purell on gloves, right? Because Purell and soap is to work on our skin. Mm-hmm. And so even if, let's say, someone puts it on gloves, like you still have to do the friction, right? So washing gloves, I mean, they're not made to be that. So I don't know that we know.
Got it.
Does it take sterilize a glove? And I think they're meant to be one use. So maybe you put them on, you go to the grocery store, and exactly, Kiki, as you were saying, they should be taken off and thrown in the trash when you're done with that interaction. And they're key pieces to PPE, masks, gloves. One can take them off incorrectly and contaminate oneself.
Yeah.
Exactly. By throwing tools into the public without appropriate education. Like, we all learn things, just if we don't get offered the information. So gloves need to be taken off in such a way that you only touch the inside when you throw them away. But if you take them off in a way and then touch them and throw them away and don't wash your hands, then you can still contaminate yourself.
Excuse me. Wait, can we wait? You all know what you're talking about because you deal with this. This is your profession. There's absolutely no way I can have a pair of gloves for every day or for every outing that I do. If I go to the grocery store, I cannot afford to throw that pair of gloves away. So I have been using the sanitizer. I didn't know if it was really working, but it made a little bit of sense to me. I have been washing my gloves with hot water and soap and stuff like that. But for those of us in the community, we don't know what to do. We are at a loss as to what to do because we don't have access to supplies. We don't want to be careless, and we want to try to follow rules and regulations. But if you have to take, I was watching you take your gloves off, Ali. I have been so bad. I have not done any of that correctly.
No, you're not bad. You're not bad.
I open up, I pull my glove up and blow air into it so I can pull them off, and then I go and wash them. But so you're saying that hand sanitizer or alcohol on gloves really has no effect. Is that what, just first of all, has no effect?
I would say we don't know.
Yeah, we don't know.
Yeah,
I've seen. You're saying it has no effect. Is that correct?
No, we're saying we don't know.
Oh, we don't know. Oh, okay.
Yeah. There are some people who've raised the concern that Yemi actually brought up on the chat as well, which is that I think some people, when they put on gloves, have like a false sense of security. They feel like, okay, I'm safe because I'm wearing these gloves.
That's right.
But then the outside of the gloves gets contaminated, and then you just go around touching stuff because,
but if you have your hands out, it's going to do the same thing. What's the answer?
To wash the glove. So I think that gloves for routine daily life are not necessary, and that especially if you're going to use hand sanitizer anyway, then you might as well just use that on your hands. And that gloves really for like high risk stuff like in the hospital, but that but that otherwise, I don't think that the people you see wearing gloves doing the, like what Yemi said, like going into the grocery store, but then just touching everything with the same set of gloves. I don't think that's helpful. And it may actually be worse. And so.
So disheartening to hear you say that. Oh my gosh.
But
It's so
let
disheartening.
let me say something more empowering. And that you don't need the gloves.
Yeah.
What we mean. So you're okay
One less thing.
without the gloves. So the key is, for instance, let's say you're going into a grocery store. Having a routine of saying, okay, I'm going to check my phone for whatever I need, and then I'm not going to touch my phone. You put your phone in a place where you're not going to touch. Maybe you get out your credit card and you put it in your pocket in a way that's separate from your whole wallet or your cash or whatever you're using, because a lot of places are asking us not to use cash. Whatever. But that being said, go in and do your shopping. You're going to touch different things, but maybe do things like, if you really want to be careful, some people talk about a coaching way of put your dominant hand, if you're right-handed, into your pocket and touch stuff with your left, because generally we touch our face without remembering it with our dominant hand. You know, possibly. I'm not saying, you know, torture yourself, but touch what you're going to touch, but remember not to touch your face. Get done with your shopping, get out of the place, Purell your hands, and then you don't need the gloves. Now you're touching different surfaces, as is everyone else. Remember that those surfaces have been like that forever. They've got the flu on them. They've got the common cold on them. They've got all kinds of things on them. This is no different. So the washing hands is the key. And while you're doing those things, don't touch your face.
See, that's the interesting thing. It coincides with what Ari talked about in terms of the advocating portion. Because let's say you go, like, for example, some places are specialty stores where they have lines that are people 6 feet apart all the way down the block, so nobody wants to wait that long. Yeah. Then you're able to go to like a Lucky's where they don't have a huge amount of traffic, and they have those sanitizing stations right as you walk into the door. The only problem is a lot of those stores, once you finish your shopping, they're shooting you out another door where that sanitation is not there still. So it's like, you know, if depending on the circumstance, if you guys are so much more into it, advocating to them to have those sanitation stations at each end of the store. So whichever way you come into, you can always have an alert to use that. Because what I'm seeing in a lot of places in department stores, grocery stores, is people are walking in with their hands in their pockets until they grab a cart. When they grab a cart, one person is holding it with one hand, and then there's another hand that's in their pocket. So they're thinking, okay, as long as the disease is in my pocket, then I don't have to worry about touching anything outside of my pocket and possibly contaminating my hands. But then that gives me the opportunity to keep from touching my face. But then also once I leave, I can re-up on all my sanitation and get out of there safely.
I just also want to give a little bit, just to zoom out and give a little bit of a perspective about transmission. I think, you know, these are all good, cautious measures that, like, a brief trip to the grocery store with just good hand washing and not touching your face is incredibly unlikely to cause you to get coronavirus. They're just incredibly unlikely. So, and just to give a little bit of like sort of data and stories around that. So the first case of community transmission that we had in San Francisco was a case that I was involved in, actually at a community hospital, St. Mary's Medical Center, where we have a group of UCSF doctors that cares for patients there as well. And so the patient had actually been in the hospital for a week already in the ICU, and then was transferred from the ICU to our service. And I had been following the changes in the CDC guidelines. Long story short, we tested him. He was positive. He hadn't had any travel, and he had been, and almost 150 healthcare workers were exposed to this patient without wearing any of the proper protective equipment. They weren't wearing gloves. They weren't wearing gowns. They weren't wearing masks. They weren't covering their eyes because they didn't think they thought he had something else. And And this is for a week in the hospital, really up close stuff, like leaning into this coughing patient, listening with your stethoscope, you know, being in the ICU and all this stuff around his low oxygen and the therapies that he'd gotten that like bring out coughs and particles. Nobody got sick. None of the healthcare workers got coronavirus from this patient. And so, and those are really high risk, close, prolonged contact exposures. And so I really just, that's one story, but there are many others like that. We have a very similar story from our colleagues at UC Davis, a similar exposure in Vacaville. So those are just the local stories. And there've been some published work around this as well. So clearly, just from looking at the world, it is contagious. I'm not trying to like totally sugarcoat that, but even looking at places like Wuhan, China, New York, other areas that have been real hot spots, it's still like close and prolonged contact that is the primary driver of the just spread of disease here. So these casual things and touching surfaces and stuff, much less the cause. And I think still good to be cautious and to, again, wash our hands, not touch our faces, and have an awareness. But it's also important for us to remember that this is not as contagious as many other things that we've dealt with in the world by a long shot. And
Chickenpox is way more contagious. Chickenpox is way more contagious.
Yeah, and even like close household contacts, like I'm talking about people who like share rooms and beds together. There have been like some estimates that the transmission from somebody who has a confirmed positive case is like around 10%. And that's like as close as it gets, right? You're sharing the bathroom, you're sharing your bed. Like, I mean, so even that is not a guarantee by a long shot that you're going to transmit the disease. So I just want everybody just to give a little bit of reassurance and back up and use the data around that. And as Eileen said, we've been actually I think a mix, we've been very fortunate locally. I think it's a mix of really good public health leadership and the public actually paying attention to the leadership and doing what they're supposed to do. And then also probably some just luck. But maybe we can transition. If I can just share my screen for a moment, I'll run through the numbers for everybody and just.
Can I, before you do that?
You got a question? Can we, okay, never mind, go for it.
No, go ahead.
Let me just, I was just gonna answer Janelle's question, and then can we take that question right after?
Sure.
Janelle, I believe it was your question, like that you read about, is California immune? You know, what's going on there? And we are, and I think that's a good segue, and then we'll take the other question, and that's that, so we've been wondering if actually, because we have so many people, so right now we think, when the epidemiologists have been looking, so those who study how these, you know, infectious diseases travel, we think that our contact with coronavirus did come from Asia, whereas a lot of New York's was repeatedly inoculated from Europe.
Yep.
Now, again, there's no blame there, but just the fact that that's where it came from. I'm sure that we have, quote, contaminated the world in other ways from the US. But that being said, we've been wondering, not only is it the physical distancing and the fact that our healthcare system has had more reserve to help to care for all of these patients who did get sicker, so we've been able to have a lower mortality. And also we do wonder if little bits since October, November, December because we have more flow of people coming and going from Asia, given where we geographically are, maybe were we kind of little bits being inoculated with colds. You know, you go to the clinic or hospital and we swab you, we test you for flu A and B, we test you for a virus called RSV, we test you for about 6 other viruses that are the most common to cause like colds and lower pneumonias. But then we don't test for all these others. You know, those are not in the test because they don't tend to make us as sick.
Yeah.
We only right now have treatment for influenza. We give you Tamiflu to reduce the illness. So based on that, we're wondering if some of these colds that we swabbed people for on and off since October, when the cold season comes, was some of that actually this coronavirus, that some of our population here in California is maybe immune already. They got it, like maybe Kimball has it and will clear it from his system, or people get a little nasal drip and clear it and they're immune. So all of those people act as a buffer to keep us from getting infection, even though infection risk is lower. So I think that's what was the nuance of what the article may have been trying to communicate, Janelle, is that we're wondering if that's why California has not seen such a big number of cases. So I'll stop there. But we had a question.
No, that's great. I was also meaning to get back to that question, and I do just, I mean, a lot of the estimates are still, though, that the minority of the population, even after all of this, of a really small slice of the population, we're talking like 2 to 5% will have had this coronavirus, and so we're not talking about what like what you may have heard of herd immunity. To get to herd immunity, you really need like more than 3/4 of people to have already had the infection and then developed antibodies, or vaccine to develop antibodies. But so this, I just wanted to show you guys like sort of where I get the data, and where most of the data you'll see in the news actually, like the New York Times and other news outlets are using this data. So this is the global cases. It's called the Center for Systems Science and Engineering. It's at Johns Hopkins in Baltimore. And they're tracking all the global cases from all the departments of public health and governments, a bunch of different data sources. So you can see it's, this was last updated at 11 a.m. And then, so it's really frequently updated. This is the total count up here. I don't know if you can see my cursor, but 1.7 million cases in the world. And you can actually, oops, I went a little too far. You can actually zoom in on the map, and then like click on San Francisco and it'll tell you. So from this one data source, you can get down to seeing like how many cases we've had in San Francisco. If you're curious in more of the local data, there's actually been an effort by, why can't I, blocking my, hold on. Zoom is blocking my ability to move my cursor here.
Might have to exit full screen to.
Or unshare and share the new tab.
San Francisco just, yeah, thank you. San Francisco just launched just a couple days ago a data tracker that's public. It's data.sf.gov. Again, we'll send you all of these links. So if you want to see just the local data, and you can see like 7,000 people have been tested, 857 positive. So the most people who have had fever, cough, shortness of breath, flu-like symptoms, other symptoms that could be coronavirus are actually testing negative, not positive, the like vast majority.
I will say that in our population in UCSF, again, those who come to UCSF, this is not speaking for San Francisco specifically, but in our system, those who had a high enough suspicion that came to the hospital and were sick with breathing problems or flu-like symptoms, 3% have been positive for coronavirus. This is not a perfect test, right? There's some chance that you are positive, but it's still a good test. And in the clinic setting where people have said, I feel sick, but they were able to stay home, like Kimball is staying, I don't mean to keep calling you out. I mean this in a positive way, Kimball. And that he was well enough to stay home, so his doctor said the right thing. Some of those people did get tested, and 4.5% of those people had coronavirus. We are still seeing influenza. We're still seeing a lot of other viruses.
Yeah. So these are good sources for both either like the Johns Hopkins is the global data. This is the local data. And then transitioning more into, well, two other things. Wanted to show you UCSF actually, and University of Washington and UCSF were two leaders in the country, and I think in the world, in terms of putting public free information out there that's really good information, and not just for patients, but for healthcare providers too. Like a lot of us have had questions and sought information and need these kind of reputable sites. And so UCSF has a patient-facing page that has frequently asked questions, has information about visitor restrictions, preparation and response to coronavirus. I think transitioning into the questions about sickle cell disease in particular, and given this forum, I think it's important for us to talk about. Bimpe pointed Eileen and I to this information, both from, I'll show you two websites. This is from the American Society of Hematology, or ASH, has a frequently asked questions about COVID-19 and sickle cell disease that's put together by a bunch of experts in the field, and has really great answers to common questions. And then this surveillance epidemiology of coronavirus under research exclusion has focused on the reported cases of coronavirus and sickle cell disease patients. And I'm actually not sure if this is global or national, but
I think it's national.
National data. Yeah,
Yeah.
so 46 cases nationally in the United States of coronavirus within the sickle cell disease community. Did you want to say anything else about these sources of information, Bimpe?
Yeah, I would very much. I can tell you that with this registry, these are reported cases. And so all of us are close colleagues. We work closely together. And I, in my part, have been trying to disseminate this registry. It's run by the sickle cell group, the pediatric sickle cell group at Medical College of Wisconsin. They are trying to gather data from the United States and globally for children and adults with sickle cell disease who get infected by COVID. But there is a report, we have to actually report the cases. So we can all, I think Ari can cycle through it.
Like
but it's actually a case report form where if I had a patient that I was taking care locally in Seattle with COVID, I would go into here and be able to enter de-identified patient data. So nothing that can identify the patient, but it would say which region of the United States that I'm reporting from, so that they can group the information by region. And it's very helpful because it gives very specific information about, what kind of sickle cell disease the person has, whether or not they are on any disease modifying therapy, and what their presenting symptoms are. It's a very helpful resource because, lots of our patients are asking, do you actually, what would happen if we were to get this COVID? And it's not a perfect reporting system. So this doesn't capture every single person with sickle cell disease in the United States who has tested positive for COVID. But, we are reporting or trying to report, or at least I'm spreading the information any which way I can so people can report the cases and we have real world data. But it will take a little while for this to mature to something that is generally or universally applicable. But you can see, as with many other complications of sickle cell disease, that it's mostly in people with SS disease. And that could also just be the fact that they are the ones they make up the bulk of who has sickle cell disease to begin with and tend to have more complications. And so they may have already had an episode of acute chest in the past that might prime them into being more susceptible to the respiratory complications of COVID, or they may have other chronic complications of sickle cell disease that makes them a little bit more vulnerable. But in and of itself, we don't think that people with sickle cell disease, we don't think that they are, like if I without sickle cell or somebody with sickle cell were to be in the same vicinity of somebody who was positive, I don't necessarily think the person with sickle cell has a higher risk of getting it. But if they were to get it, they may have a higher risk of complications. And the bulk of the complications a lot of this information can also be extrapolated from the H1N1 pandemic from over a decade ago. And so most of the complications that we're seeing then are similar to what we're seeing now, with respiratory complications very similar clinically to acute chest. And so for our colleagues who are taking care of the patients in the hospital, my role as a sickle cell person is just to liaise with our colleagues like Ari and Eileen to say, okay, could this be acute chest? Could this be COVID? A lot of symptoms overlap. These are my recommendations for treating. And then, you know, we can assess and see how the patient is doing, and we can change tactics if it's not working. Some patients are requiring blood transfusions because their bone marrow isn't producing enough red cells to compensate for how quickly it's being destroyed with their crisis. Many patients present with acute pain related to, as you would with any illness, really, you could have a painful episode that's severe enough to go to the hospital. So I just wanted to point out that it is very premature data, but it's helpful information in that it is sickle cell specific, but there is a reporting bias. It doesn't capture everything, but it is very helpful for those of us in the sickle cell field and outside of the sickle cell field who end up taking care of patients that might be infected.
And I will say that as those taking care of patients, so far we've not had anyone who has been positive. We've had a couple of patients at UCSF get hospitalized for pain episodes that have been significant. And honestly, we will move forward because what we are really worried about is acute chest syndrome, which we all are aware can have really high consequences and even mortality. And so we are primed to treat every situation where someone comes in with to say that someone has acute chest syndrome, it's a very, what we call inclusive. So we have 4 or 5 criteria that usually helps alert us to be concerned about it. And if someone has just one, we move forward because we know that transfusions, antibiotics, oxygen, that the treatments that we give, the treatments to help open up the lungs, the inhalers, that those are very effective. And so we pair with our hematology experts, but already have a very quick response, like you'd said, Bimbe, to make sure that we are not attributing it that it's just the virus, but that the body's interaction with the virus that can be incredibly harmful.
That's exactly right. There are some other, in addition to this registry, so this is just a registry, it's not telling people how to treat or how to manage complications of COVID. It's a registry to report the frequency of cases and whatnot. So the ASH website is very helpful. Another useful piece of information, I don't think I can share my screen, but
I can let you share if you.
Okay, I'll share it, and obviously this can also go into the information that's disseminated to everyone. So I'll just share very quickly. So the Sickle Cell Disease Association of America did put out helpful information that's updated on a weekly basis. So specifically for patients and their caregivers or their family members, talking about in layman terms, talking about COVID and what it means for the sickle cell community. As again, I mentioned, a lot of this information is extrapolated from the H1N1 pandemic from 2008, 2009. And then specifically, they also have a version for providers, and that's updated on a weekly basis, talking about what we should do if a patient were to come in with, X, Y, and Z symptom, who should be tested, and, what are the streamline of information that we need to do to make sure that our patients stay safe, even if they are not COVID positive, but they're in the hospital and we're co-managing COVID patients. So I'm happy to share that information as well, or I'm not able to, let's see.
It says, I stopped sharing, so you should be able to see a share screen button at the bottom.
Yeah. One quick, so I will.
Guys, before we get into this, can we address Mr. Capola's question, and then we'll take a quick little break, give everybody some time to just grab some water, and then we can, this is all good stuff. I just don't want anybody to kind of lose track of anything, so kind of take a quick little break. Does that work?
Yeah. Can we take the question first?
Yeah.
As a carrier, sorry to go back to this, but anyway, Antoine brought up this comment some time ago, and also saw frontliners putting their shoes in either Clorox or bleach solution. So what is the possibility of carrying COVID-19 into your home on the bottom of your shoes?
Really low, I think. So, I mean, the one piece of data that I've seen on this is actually a little study in Singapore where they went around measuring for like actually trying to find coronavirus in and around a patient's room with known coronavirus. And they did find that like surfaces within the room are contaminated. But then even without even before they did any routine cleaning of the room, they went around and they tested the air to see if this was part of the evidence for like, is it airborne? And there was nothing in the air, nothing floating in the air. Surfaces did get contaminated, like the patient who's sick with coronavirus, their sink and stuff, and like the bed rails, the things they touch. But then on the provider, they actually tested providers' shoes, and they found on like one provider's outside of the top of their shoe, this is in caring with a patient with coronavirus again, so high risk exposure, that sampled in the room that they actually were able to find coronavirus on their shoe, but then they couldn't find it anywhere by the time they even got to the door. Like, so it's not on the floor right outside the room. So that suggests that even if it does get on your shoes, it's gone by the time you get home. Like if it's gone by the time you walk from the bed to the door, and it's not anywhere found on the floor outside the patient's room, I am personally not worried about spread in. We take our shoes off in our house anyway, but that's a different, but that's not something I would worry about.
Yeah, I think oh, please go ahead.
I hear you. I thought you were done.
I got one more point. Okay, what was the service that the inspectors found on the ship that held the coronavirus alive for 17 days? Do you know what the service was?
The service?
Which service? Oh, so I don't know that. So that's a good question. So this whole thing about the 17 days on the ship. So that was not, again, that was like what we were talking about earlier. It wasn't like a test for like virus that could actually infect you. It was like little bits of the genetic material of the virus. So that's, and those are such sensitive tests that might pick up even little bits of virus that got obliterated and left behind. 17 days out, but like, I don't know the direct answer to your question, but the big caveat is that we don't know that that's like capable of infecting anybody. And we have to be really careful about interpreting like that level of testing to like real life scenarios. And other studies of even this coronavirus living on surfaces show that the amount of the coronavirus that's around drops off really fast. And it turns out the dose actually matters. So like being up close and personal with someone who is coughing out coronavirus, like for a prolonged period of time, that's one level of risk. And even that we know doesn't guarantee that you're going to get infected. In fact, most people don't. And then these other things with surfaces, I think that the drop off is so fast that we also have to remember like even one viral particle is not likely to be enough to like cause an infection.
Yeah, and surfaces are, and also the epidemiology right now doesn't support that surfaces are staying, if surfaces were staying contaminated with live infectious virus for that long, the numbers of people who would be infected would be even exponentially more. So the numbers of people infected, I mean, there's, we don't know everything about this virus, but we know a really good amount about how these kinds of flu-like viruses are transmitted, how we kill them, those kinds of things. So really thinking of this as a more aggressive flu than usual, but just remembering that our population just isn't immune. So that's why it spreads more readily, because it hits people who aren't immune. Whereas if you have the vaccine to the flu, it stops dead any spread. So, I mean, not to put in a plug, but please get your flu shots. If this taught anything to anyone in the world, it is that when these vaccines are offered, It's exactly to stop this kind of pandemic. And even with the flu shot, 45 million people got the flu this year, right? Now we're talking about 1.7 million people. No one takes that lightly. We have not seen the end of this. In other places that it's heating up, whereas we in California may be cooling down, but that can always resurge. And so just being clear that trying to, again, that bigger view of putting all these things in perspective, the same precautions and care you would take in avoiding the flu, avoiding a cold, avoiding these other things are the exact same precautions we should be taking with coronavirus. So this isn't some super bug. It's just a new one, and we don't have immunity yet. So.
All right, cool.
Excuse me. It's Kiki. I would just like to say where I was very disheartened a little while back and was feeling very, very like, well, what do we do, especially for our sickle cell population and those of us that even carry the trait. Thank you all for what you have been saying in the past half hour. It has made me feel a lot better, and it's made me feel like I should not yell at the man in the store who's running around on his phone, talking loud, walking past me with shorts on and flip-flops and spewing his spit everywhere, that I should not yell at him, put a mask on. So I won't do that. I will try to control myself. I've already told a couple of checkers that they should put a mask on, but I will be better. So thank you all for making me feel a heck of a lot better. And
thank you, Kiki.
I have to dash, but I want to say this. Please put back up that one website that said secure. What was that?
Kiki, we're gonna get back to that. We're just gonna take a quick little break here just to give everybody some
we got about a half hour left.
Right.
Do you want to just push through then, Nadina? Because you wanted to take the schedule I was given was we were going to take a break, but if you just want to push through, we can just push through.
Well, thank you all so much. Take care. Stay safe. I love you all.
Thank you, Kiki, for joining. We really appreciate it. You have a good day and stay safe, my sister.
Bye, everybody.
Bye. Bye.
Bye.
I just want to reiterate one thing that Kiki brought up, and that's that what we would love to do is to empower you with the best ways to remain cautious, but to help relieve some of this anxiety. Because the truth is, one of the best ways that we stay healthy against anything like this is continue to get good rest, good sleep, stay hydrated, stay fit with Kimball and Antoine's help. These things boost our immune system and help us fight if there's a small chance that we get exposed to something. So, and just to remember that there's still, not in an apocalyptic sense, but there's still flu out there. There's still other things out there that can make us sick. So these cautious steps will help protect us against that.
One thing for everybody here, if you haven't heard, at the end of our conference, there's going to be an opportunity for us to send you this information from the best known websites that we have for you to get the correct info. If you feel like you want to, if you're not a part of any listings that receive information from Sickle Cell Anemia Awareness of San Francisco or Cayenne Wellness or any other organizations that we have a part of this meeting, please put your email address in the chat box to your right, and we'll jot it down and we'll make sure that you get this information.
I also want to add, is there anybody still on the line that a question that they asked was not answered?
We have a few that Eileen has logged.
Maybe I can read them out. I think oh, sorry, go ahead.
While we're doing that, I've actually been messaging privately with a couple people. So I thought it might be, if it's okay with people, I promise we'll answer these questions, but if it's okay, I would love to pivot a little bit to from some of the fact sharing that we've been doing and the stuff around us staying safe as individuals to some of the other impacts on the sickle cell community. And the changes in the hospital have been really dramatic. Like visitor restrictions have been really severe, and I think that's impacted all of us as providers, and then of course as patients, and then as like advocates for patients and families of patients. And with her permission, I had asked Janelle if she'd be willing to share a little bit, because she was recently hospitalized at UCSF, and she said that she'd be okay sharing a little bit of her experience, and talking about what just how visitor restrictions, the inability to have people in the room with her, impacted the hospital course, how that was different.
Yeah, it was very different. Like nobody could come into the hospital, no visitors. I know Nadina wanted to come visit me a couple times, but was unable to because of the restriction of being scared to allow someone who's sick visit a patient that may have the COVID. I know that my dad was very scared for me to even catch it because I was on the 14th floor, and they had the people that had the COVID-19 on the 15th floor of the hospital. And it was crazy because I was in the emergency room a week before the COVID came to the Bay Area, and like when I came to the hospital, they was all wearing masks and stuff. So I was like, wow, it like dramatically changed like overnight. It was just crazy. But they're very cautious of how they let people in the hospital. They're checking people outside now. They have a little tent. If you don't have any of the symptoms, then you could go into the hospital. But if not, then you have to go into the tent outside. But they're I actually kind of like it. It gives me a sense that, I can't catch it, even though I was there at the hospital. I wasn't by anybody, and I was kind of scared about the ventilation of the hospital. So I was asking questions to people that work there, like, how's the ventilation? How do you know it's really safe for them people to be upstairs and not being downstairs? Because, I don't know. I was just always curious about that. But they said that the way that the hospital was built, it couldn't withstand all that or something like that. So, but yeah, it was a very different experience, I'd say.
Janelle, thank you. It's I certainly wouldn't have put you on the spot without your permission in advance, and but thank you for sharing that. And I think you brought up a lot of really important points, that like the isolation, and then also this other side of it that was the considerations of safety. And I'm glad that you felt safe from some of the extra precautions the hospital was taking. And I'm wondering if you could speak a little bit more to that flip side, that isolation, and just like not being able to have people like Dina in your room with you.
Oh yeah, it was. Yeah, it was different. You have to really be strong enough to like cope with being in isolation, because it can really get to you. I'm thankful that I asked my cousin to bring up my hospital bag, because I left it at my house. I usually have a hospital bag in my car, and I bring with me to the hospital visits in case I go inside there. But it had my art notepad in there, so I was like drawing the views of the bay. It was so pretty. Like I had a very, very beautiful view of the Golden Gate Bridge and stuff. So, and I kept seeing boats coming in and out of the bay. So it took me back to like enjoying the simple things in life, looking out the view and seeing life, even though I'm not out there. But and I did see a lot of people wear masks and running on that track behind the hospital.
Oh yeah.
So, but and there was a lot of people out. I thought that most people would be indoors, because of the whole scare. But I don't know. Just some people listen, some people don't, you know. But it was really mind-boggling to be isolated.
Yeah.
Yeah.
Could I bring up a little point about that as well? So I don't know if this is, I think it's wonderful that you have a hospital bag. I hadn't thought about that. That's something that I'll definitely take back to my patients, to just pack a bag just in case. If these are such uncertain times. But one thing I had heard, and one thing that I have found is, you know, during these weeks of physical distancing, it's so wonderful to connect on this sort of media, such as Zoom or something similar. So I wonder if, I know it's difficult, I think, for some of the older patients, or perhaps people who don't have access to a smartphone or a computer, but I think visiting friends in the hospital via Zoom is another opportunity to narrow that distance, where you can't see the person and touch them and hug them like you normally would, but you can still see their face, and you know, the love and the care still can come through. So that's another thing to maybe consider if you're able to do like a FaceTime or a Google Hangout or a Zoom thing with friends and family. I've heard that people have done that to, you know, just to check in, and that way it doesn't eliminate, of course, the loneliness, but it can decrease it somewhat. So I think that might be a good thing to add as well.
Yeah, I
We've
forgot.
made
I
a lot.
did do
Oh, no, go ahead.
a little bit. I'm sorry. Go ahead.
No, you go ahead.
Oh, I was saying I did forget that I did do that. I did a lot of social media while I was in there with Snapchat and Instagram and Facebook, and I have some people, because I've shared my experience being in a hospital dealing with COVID-19 and just having sickle cell, because people thought I was in a hospital because I had COVID-19, and I was like, no, I have sickle cell anemia, you know. But I did reach a lot of people that are now following me on Facebook that have sickle cell anemia. I didn't realize, you know, so many people. I mean, when on Instagram, when I tag a lot of sickle cell warriors, sickle cell survivor, you know, sickle cell SS, you know, just anything sickle cell, you know, and I tag it, and I get all these people. But you know, somebody took one of my roommates, that was my roommate in the room. She was like, you should tag anything that comes to mind, because I don't really tag, but I have started doing that, and there's a lot of people out there that suffer from sickle cell.
I had a question. I'm not totally sure. She doesn't have to answer this if she doesn't want to. But what I had mentioned earlier on in our discussion, where we were introducing ourselves and what our CBO, Sickle Cell Anemia Awareness for San Francisco, is trying to accomplish. As far as unity, I wanted to ask Carolyn Raleigh, because Carolyn Raleigh is in the Southern California community, and if she cares to share or has the ability to, I was just curious to know what she might be experiencing down south with a lot of patients that she's dealing with there. Carolyn, would you be able to share with us a little bit?
Yes, thank you. So down here, both San Diego, LA, Central California, some of the things that we're dealing with. So one is that, unfortunately, doctors are only given 7-day prescriptions to patients. That's actually a big problem. I've attempted to address that issue with several doctors, and I can't reach them. So you have a catch-22. On the one hand, patients are going into infusion so that they can actually stay out of the hospital. So that actually is helping. However, they're also not getting pain medication. So then what happens is it leads them to, unfortunately, have pain. We want them to stay out of the hospital. And as a result, the patients are basically caught in between physicians not wanting to give pain medication. Some physicians are continuing infusion, which is what we want them to do, so they can actually stay out of the hospital. However, the infusion centers need to be separate from where from the ER. So I'm trying to inquire as well, is so many hospitals to follow through with. I'm trying to follow through to find out, so where are you now having the infusions for the patients so that they can stay out of the ER? Are you actually separating them? And these are the calls, the multiple calls that I'm receiving with respect to patients wanting to stay healthy, continuing their infusion, and not wanting to go in. The other issue, which is a big issue for those of our patients that are working, I have a patient who works in the ER and has said, I need to stop working. I said, I agree with you. I've had to actually get on the phone with HR to find out what we could do. This particular person is per diem, so therefore they're not qualified for unemployment. So I then had to ask, okay, they can't go on unemployment, they need to make money. That HR person told them to go on SSI. I said, nope, because they're working, this will not last long, and messing with SSI is a big problem. So I just asked if they can just reassign them so that they're not first responders and they can still keep their job. This is a big issue. He was just one of several that have had to talk with the HR. And this is only if the patient has identified themselves as having sickle cell. Many people with sickle cell do not identify with their employer that they have sickle cell. So that becomes a problem if they're wanting to have accommodations. The other issue, I think, is just in terms of not having, our CHWs have called and wanted to find out what they needed. Of course, the number one item that they need are masks. Of course, there aren't any masks. They need hand sanitizers. So we're asking that their caregiver can go out on their behalf and be able to get the items for them. So these are just a few of the things that we're dealing with. The other thing that we're dealing with are myths. So one of the myths that I have not seen on this list is they're asking, is it true that people with sickle cell disease are immune from COVID because they can't catch malaria? So I've had to say no, not for trait nor for sickle cell. This is just like any other infectious disease, like the flu. Everyone can catch it. I just need for you to stay home and to be safe. So, but that is one of the myths that is actually going through. I'm not sure if you guys have heard it, but that is one of the things that I've heard quite a bit, is that people are in the sickle cell community are feeling as if they are immune because somehow they're associating malaria with wherever they've heard the information that malaria can somehow help this. Oh, well, if I have trait, that means that I can't catch malaria. So they're deducing it for themselves in their own mind. And I'm reminding them that that is not true. So I think one of the issues has to do with dispelling myths that are floating around. So that's just a few. Thank you for asking me. And those are some of the things that we're dealing with.
Thank you for the share. Definitely. Eileen?
Yeah, Ari and I were just texting sort of separately around how, being mindful of everyone's time. We have about 10 minutes left. I think number one, just letting you know that we will certainly send out these links. We will send out the information that we've been talking about. This is recorded. I personally will look up and find what information we do have about possibly sort of masks and how best we can do that. But again, remembering it is very unlikely to get anything at the grocery store. Good hand washing and the 6 feet distancing is the key. But I wanted to kind of throw it to the group and see, we can do kind of one of two things in the last 10 minutes. We can do a share around as a conclusion to this wonderful conversation of sort of one practice you have toward resilience and one thing that makes you resilient. Or we can address sort of the theme. There's a theme of several people asked, how does this end? How do we know this is over? What does this all mean? Just sort of respecting that with this 10 minutes, how do we want to spend that time? But I do want to end it on a positive note. I know that there's been a lot of concerns and I think a lot of us have you know, it's been very challenging both health-wise and socially to do this and have such a disruption in our lives.
Well, I just want to make this statement. I'm back to the questions, and that if anyone feels like they didn't get their question answered, please reach out to me, and you have my email. If you don't, I'll put it here on the screen, and we'll try to get those answers for you, because I'm not certain that they were all answered.
Agreed.
Yeah.
So I don't want to just leave you all just hanging like that. If you don't feel like, that's why I asked the question initially. So if anybody could think of anything or had some thoughts about something that they didn't get the information on, they could say it now within these last few minutes. If not, then like I said, please forward that information to me, because we don't want you still, you know, leave the line and say, well, they didn't answer and they didn't tell me this or they didn't tell me that. So just know that I'm still here, and we can still, you know, move forward with getting, you know, the information that you need.
Yeah, as are we. I mean, this was meant as a anchoring first discussion.
Right, right. And we'll be planning another one. I'm not sure when, but
when we get to our close, I'll close out, and I'll give you an opportunity to know kind of what's coming up. And then
okay, so you want to, okay, so does anybody have any suggestions with what they'd like to do with the last 8 minutes besides close out?
Well, I do want to make sure, I think it's important. It's something that we don't speak about, but how will we know when it's time to reopen? And there's 4 benchmarks I just wanted to share, just to get people to think.
Please.
So one of the benchmarks is hospitals in the state must be able to safely treat all patients requiring hospitalizations without resorting to crisis standards of care. So that would be benchmark 1. Benchmark 2 is a state needs to be able to at least test everyone who has symptoms. Benchmark 3, the state is able to conduct monitoring of confirmed cases and contacts. And the last one is there must be a sustained reduction in cases for at least 14 days. And I believe that the latter is something that we should really pay attention to as we continue to, whether it be our young people who feel that they're invincible, I think we need to really continue to let people know to stay at home. One of the cases that have, one of the countries that have actually had success is New Zealand. And so the Prime Minister there shut it down. And as a result, they're one of the ones that have the least amount. And they also saw a reduction quickly. And I think that that last benchmark is something that we need to pay attention to and continue to let people know that as soon as we see a reduction, it's going to be an indication that we can finally get back to moving things forward.
Thank you, Carolyn. Absolutely. So part of it is, I do want to say that this shelter in place and these really extreme societal measures that have been taken are not going to most likely eliminate coronavirus from our communities nor from the earth. What this does is it allows to keep people safer for longer. And our anticipation is that that this will continue to spread and have some illness burden throughout the world and throughout our communities, but that the goal is exactly as you said, Carolyn, that number 1, institutions are actually able to treat fully anyone who has any level of care, either coming to the clinic and getting tested and being screened and going home, being able to test and be sure that we understand what the illness is, and then keep track of those folks, but also see that that's lessening. So right now, what we're seeing, right, the stark difference is what's happening in California versus what's happening in New York, right? So where it's contained and where it's not contained is massively different. And so what does it look like when this is over is a big question. So it's never over and the coronavirus is not going to disappear. It's over in that the huge burden to the health system will actually decrease. And so people can get the care that they need at any given time to the level that they can have. It doesn't mean that it's going to become from the biologic properties of the virus interacting with someone who has lung disease. It's not going to become less deadly from that. It's going to take a long time to get a vaccine, most likely. So that herd immunity, what we call herd immunity, where enough people got sick and recovered, or that we get a vaccine, is going to take some time, as Ari mentioned. So what this looks like when it's over, and sort of on an empowering statement, is, you know, we continue to be cautious, we continue to wash our hands, you know, we may be able to be closer, but it's still no different than any other illness that we want to be careful of and not spreading to our vulnerable community. You know, I'll just share a statistic that, yes, children are more protected from coronavirus, we think, for 2 or 3 biologic reasons that I won't get into, but more than 17 children, healthy children, died of influenza in February and March. And it doesn't sound like a lot of people when we're talking about 100,000 worldwide deaths of coronavirus, but that is more than have died of influenza in children since 2009, when H1N1 was here. So just being aware that the hope is that this isn't going to be over per se, but our society restrictions will lift, and it's up to us to continue to keep each other safe. And from that standpoint, I think one empowering piece that I have is, as horrible and as terrifying as this has been to so much of our society, is maintaining that caution and care for our vulnerable population, and giving this now a huge ability. I would love for us to be able to have a forum to talk about how, as a group, could we advocate that it is absolutely unacceptable in this world that one particular population dies more of the same illness than another does. And the fact that the mortality in Chicago or New Orleans that's being seen is 40% in the Black community, whereas it makes up 20% of a community, or, you know, the fact that patients are getting sicker and are dying more is just unacceptable. So how, I guess, seeing this as never over, because then this is further fuel that it's on a national stage, that this has to be discussed again and get to the highest levels of what is the discourse and the discussion happening to change our health system and the care of our more vulnerable parts of society, that this doesn't happen again. And really kind of, I use the word target. I feel like, I guess it feels like to me is this coronavirus was floating around, and I feel like our health system targeted it at more specific people because they're the ones who are more vulnerable, because we haven't taken care of them at a baseline. So that's sort of my, I guess, soapbox, or just plea that this is, you know, our societal clamp down will lift, but hopefully this passion that it's raised in everyone will not be over.
I mean, just to add to that quickly, I think it's also pertinent to understand everything that you said, Aileen, is a very good point. I mean, we do have a lot of vulnerable populations, and, you know, oddly enough, with all the education that people are getting, especially in the 1% that have now refused to vaccinate their kids for whatever reason, this is just another reason why you should vaccinate at all times, because it's not good to not vaccinate. And I think hopefully this brings about that change as well in that aspect. And again, we're not in a society or in a world now where we cannot vaccinate. We definitely need to vaccinate. It should be something that should be on everybody's mind to do automatically. And also good cleaning procedures, you know, cleaning your hands, washing your hands.
Oh, okay.
But that is now a normal thing that we now apply to all the time, you know. So I think that's a good direction that we could head into.
Thank you. Thank you. Antoine, you want to close out?
Yes. So in closing, we had a couple of questions on the sidebar in regards to whether we're going to have another town hall meeting or anything of some sort. For those that just came into the meeting, I'd say probably 30 minutes in, maybe 20 minutes in, we advised you that we lost out on last month's AEP training with Pat Corley, which we're going to convert with her again and try to get her back into the schedule towards the end portion of the year. But with this town hall meeting, this gives us momentum once again to restart and keep our trainings going on a monthly basis. They are always going to be the second weekend of every month in 2020. And the start times will always be 11 a.m. Like I said, if you do not get the newsletters from SCAASF on a consistent basis, which go out on the first weekend of the month, and the third weekend of the month, just to prepare you for the coming things, please put your email in the chat box so that we can put you on our mailing list. The next person that will be speaking in May of 2020 is Dr. Hager. Dr. Hager practices in pediatric hematologist and oncologist in Oakland. What he's going to be spending most of his time on is adult patient care. Situations that you guys go through when you go into the space of the hospital or when you're admitted into ER. He's also going to be talking about how people are dealing with the transitions going from being a youth and then becoming an adult, and how you guys can manage that psychologically. He also has a really good idea of the upcoming therapies that have already been produced for people to take, but then also new things that are coming along and alternatives from what you may have only heard via the internet or the media platform, which is the news. He is going to be an incredible speaker for us. And the fact that he is very concise and contrite with all of what he's saying, he is going to allow us another opportunity for Q&A of sickle cell patients, caregivers, advocates, or just people that are trying to understand more about our community to speak on, ask questions like we did here, and have that open forum. So we will have those two levels in next month's training. I believe the schedule for that, my apologies for taking a break out of that, but the schedule for that is going to be the 16th
May 2nd.
The 22nd of May. The 23rd of May is going to be our next session. Does that make sense? No, it's not? Or
No, May 2nd. May 2nd.
May 2nd? Okay, well then, just make sure that make sure you put your email in there in case you're not on the mailing list, and we'll get you that update so that you can be prepared weeks in advance if we don't necessarily have everything coordinated today.
It's not the second Saturday, it's the first.
Don't worry about it. Don't worry about it. We'll get you that information as soon as possible. Just make sure that if you need it right now, send us an email or put it in your chat box so that we can put you on the mailing list and we can get you there. Thank you so much, Eileen and Ari, for all that you've done for us and the help with the preparation for this town hall meeting. I think it was incredibly effective, and I'm looking forward to many more moving forward. Hopefully this shelter in place only lasts till May 7th, but come that time, we'll give you guys an update of what we're thinking and what we see.
Thank you all.
Thank you, Ari. Thank you, Eileen. We really appreciate your time and all of your efforts, and stay safe out there on the front lines. And we'll keep you in prayer, and just stay sane.
And you all as well. And Bimpe, thank you for joining us today.
Thank you for inviting me.
Your expertise.
Bimpe, nice to have met you.
Likewise.
And hopefully we'll see you again here in California, here in San Francisco.
Hopefully.
Possible.
Fingers
Yes.
crossed.
And
You all
Janelle,
have a great
thank
day.
you for sharing your personal story and for your courage to do so, and to all of you for everything that you've done and continue to do to support each other.
Thank you.
Signing off.
Thank you.
Thank you.
Have a good day, everyone. Stay safe.
Bye.
Bye. Thank you.